What do you know about the journey to end of life? My name is Carla Carlson, and before my mom became ill with terminal cancer, I knew very little. What I learned is that while the journey to end of life can be scary and overwhelming, it can also be peaceful and deeply meaningful. The Saskatchewan Hospice Palliative Care Association is a non-profit organization that exists to support palliative care service providers through education, networking, research, and advocacy. The organization itself is not equipped to provide direct service delivery. Our role is to help service providers deliver excellent care. The association is membership-based. Physicians, nurses, social workers, spiritual care providers, home care workers, volunteers, anyone with an interest in palliative care can be a member of Saskatchewan Hospice Palliative Care Association. At some point in our lives, we may be called upon to support a loved one as they approach end of life. And of course, at some point, we will all ultimately take that journey ourselves. We hope that this video will help you see that quality palliative care can make a difference.
Palliative care is the care offered to patients and families facing a life-terminating illness. Generally speaking, and I think it's fair to say most people think that palliative care is offered only at the end of life. And in reality, that's often when we're called in. About 80 to 90% of the patients that we generally become involved with are cancer patients. The other 10 to 20% would involve other conditions that are life-threatening and life-terminating. It more is dealing with kind of comfort measures and those sorts of things rather than acute disease treatment that surgeons and or medical people and or the cancer clinic would be focusing in on.
Mother was a very quiet person. She didn't let you know if she wasn't feeling well. She kind of kept that part to herself. So when we did find out that she was ill, it was almost trying to convince her of what she actually was diagnosed with. You know, even with the doctor telling her, we're not sure that it really registered with her, unless, well, what she was diagnosed with was a cancer. And of course, that isn't a word that you want to accept hearing. She wanted to be in her own home, and you know, she just wanted to be in her chair, and that was it, yeah. They give me a lot of booklets, pamphlets as to what to expect, what to be looking for so that you were prepared. And I don't have any nurse's training, and things that I was doing, they were comfortable that I was doing it satisfactorily, because I ended up giving her medications, and I thought, oh my gosh, I don't give needles. I don't even like getting them myself, let alone, you know. And they set up a butterfly on her so that I just had to administer it that way. And yeah, so I got a lot of good, helpful information as I needed it. And they were there on the phone, anything happening, a quick phone call, and I would get an answer right away. I never had to wait. I felt I could give her more care at home than the hospital could give her, because we knew that if she was in pain, she wouldn't be telling everyone or anyone, so she'd be suffering on her own. She would have never called for help in the hospital, and this way I knew that she'd get it, and she deserved to get it.
One of the things I think that most patients and families fear is pain. And quite honestly, from the palliative doctor and I think medicine point of view, pain is one of the major symptoms that we try to ease. In addition to that, nausea and vomiting, shortness of breath, constipation is often a huge issue. Sometimes delirium or a little bit of emotional and mental upset and confusion tends to creep into the picture, especially as diseases advance. So those are the physical kind of things that we often are called upon to relieve.
He was such a gentle man himself, and I think that the staff really loved him as much as he loved them. They gave him such gentle and special care. You know, I often would hear them singing to them as they were giving him his daily bath, and just when they would come into the room, it was always, "Hi, Al, how are you?" And, you know, a real meaningful contact with him. Which was very important for all of us to see that.
So this was a housewarming party. We were dressed as our favorite drink. And my dad was a scotch and soda.
Okay.
She was a blue nun. He was a red eye.
Very creative.
Yeah, it was.
The morning that we knew that Dad was declining very quickly, they moved us into the palliative care room. And it's where patients go for their last hours or days. It's a wonderful room. It's been totally refurbished by the Beta Sigma Phi organization, and we were made to feel at home there. A kitchenette, a large sofa, chairs to sit around the bed, comfy chairs, and the staff, if we even so much as put our eyes around the door, they were there to find out if we needed anything at all. And they were just amazing, but I also felt for them in that they knew that they were losing someone that they'd become very attached to. Knowing that his last hours and minutes were comfortable and at ease, that there was no stress, there was no traumas, it was just, for us, it was a very, very easy, soft, like I said afterwards, it was like he slipped out the back door.
We try to make it a seamless provision, whether they're in hospital, hospice, community, long-term care. They have access to physicians, to nurses, and for the most part, to all of the other non-medical support systems that they need. They do have access to therapies, they have access to social workers, they have access to psychologists. Spiritual care is provided in the community, and the volunteer support group is extremely important.
One of my clients is in her own home, and therefore I have helped her do some housework and laundry and that sort of thing. Some of my clients have been in the palace or a care home facility, so there's not too much to do for them literally other than giving them water and that sort of thing. But I mean, their meals are prepared for them and everything's looked after. For the most part, a lot of it's just listening to them. You know, I'm an ear to their problems and telling the story of their life or whatever. If they're already into a state where they sleep a lot, they're highly medicated because of pain that they're on or whatever, I may just sit with them and pray. So they don't honestly know that I'm there, but I suppose maybe deep down they do. And other ones that I help on a more physical basis, like I mentioned, say maybe doing a little bit of housework or whatever, well, of course, somebody has to help them. And so I know they're very grateful for that. It's not just for the patient either, the client, it's also for the family. A friend of mine was dying, and we, myself and another friend, spent the evening with her and through the night so that her husband could sleep. She decided she wanted to stay at home. Those were her wishes, to die at home. And so the family tried everything they could to accommodate that. And so with the help of volunteers, they were able to do that. Tell them I'm coming by for a visit. I'll see them in a little while with their beautiful She had such a fantastic attitude. She died with a great deal of dignity. And I think maybe that's what I want to portray to others, to let them die in the most peaceful and dignified way that they can.
It really is difficult to, not only from the medical point of view, to devote some of the very complicated medical things that arise, but let's take the social issues and the spiritual issues, the emotionality, the tremendous reliance on a belief system requires a little bit of extra devotion to the patients and families requiring it. It's not just a matter of prescribing a drug and away you go. The physical part of it sometimes is fairly easy to treat, but bringing everything else in to try to relieve kind of all of the other areas that involve the suffering package really requires a pretty nice multidisciplinary unified approach.
The differences between First Nation and Métis people and other cultures and faiths is not that we're so different in what we might want at end-of-life care. It's that there's been such a history in our relationships because of the effects of colonization that I think there's been hesitancy and fear to open up dialogue. For example, when we talked to nurses and other healthcare providers and asked what some of the questions they had around First Nation and Métis patients at end of life and in palliative care, some of the large questions were around why are there so many people in the waiting room? You know, why are there 50, 60 people in a waiting room? What purpose is that? Why is it that someone wants to smudge? Why is that so important at end of life? Why do they call elders in? What's the role of an elder? Those kinds of questions. And so then we went to our elders and our community members as a team and asked, what would you want to say to healthcare providers about end-of-life care? What are the needs? And those questions that healthcare providers asked, they were answered. And we captured that on video. And it was quite profound and quite helpful in order to bridge that disconnect, that communication disconnect that was there. I think the whole key here is really being able to get out of your own comfort zone, because it's not about what you believe or don't believe. It's about finding a way somehow to meet an individual's needs, regardless of what a hospital setting or a clinical care setting the restrictions might be. Finding a way to meet those needs is of critical importance, regardless of who the patient is or what their cultural background is. Because at end of life, in particular, it is extremely important to meet those needs.
The Saskatchewan Hospice Palliative Care Association strives to educate the public about end-of-life care. We also work to create a vision for the future through research and education, through networking with our members, and through partnering with government to consider creative solutions in service delivery. Our organization is partnered with the national team, Canadian Hospice Palliative Care Association. This connection helps us understand and contribute to national strategies and also to share resources and ideas with associations across the country. The journey to end of life is unavoidable, but it doesn't have to be fearful. The Saskatchewan Hospice Palliative Care Association is working to help you and your loved ones walk the journey together in strength, knowledge, and comfort.
If you have program ideas that you'd like to see on Local On Demand, write us at max.local@sastel.com. Max Local programming is now available online at maxonline.sastel.com.